Hello and welcome everyone to another episode of the Comfort Care Expert Podcast. I'm Megan Lifto, a palliative care clinical nurse specialist.
And I'm Elena Prendergast, a palliative care nurse practitioner. And in today's episode, we're diving into a crucial topic that's close to the hearts of compassionate nurses like us: pain management, especially for patients nearing the end of their lives.
That's right. And we're actually talking about the pain. This is the Comfort Care tool. We're under the comfort section, and we're going to be covering the pain interventions that are listed here. For your own copy of the Comfort Care tool, you can go to my website at comfortcareexpert.com and download your copy. And so we're going to be exploring even the ethical responsibilities of nurses, the importance of pain control, and best practices for managing pain for those that are nearing end of life.
Megan, nurses play a pivotal role, as we know, in patient care. And one of their ethical responsibilities is to act as a patient's advocate. Now, if we went back to the American Nurses Association Code of Ethics in Provision 3, it states that the nurse promotes, advocates for, and protects the rights, health, and safety of the patient. And this is especially true when it comes to pain management. Now, our goal should be to ensure that our patients are as comfortable as possible with whatever time they have left.
Absolutely, Elena. Pain control, it's essential for all patients, but it becomes even more critical for those that are nearing the end of their lives because it takes away so much energy that they could be doing internal work, such as making peace, finding hope, finding meaning within the circumstance, as well as just being able to visit with their loved ones and family with the time that they have left.
You're absolutely right. When it comes to managing pain at the end of life, opioids often play a significant role. Now, we can look at scheduled around the clock administration or continuous infusions like PCA pumps. And those provide, as we know, consistent pain relief along with PRN or as needed dosages of opioids for breakthrough pain. Now, here's an important point: the dosages of opioids for pain control in some populations can be much higher than nurses may be accustomed to giving. If you look at that comfort care tool, the second bullet states that there is no maximum dose of opioids for pain control.
Yeah,
Every time we give a dose, it should be patient specific and titrated as needed.
Yeah, exactly. It's important to also differentiate between, is this patient opiate naive? Are they someone who does not take any scheduled
Right.
opiates, or are they opiate tolerant? Somebody who has been on opiates for years or months or years, and so they're going to be at a such higher dose. So for patients that are opiate naive, you're going to start at a much lower dose. So you start slow, go low. So maybe it's oxycodone 2.5 milligrams for an elderly patient. And you could even start out every 6 hours just to see, what's after 1 hour when it peaks, when that oral medication peaks, being like, okay, how effective was it? And then also too, how long does that pain control last? Because then if the pain isn't lasting the full 6 hours, then that elderly person could be on 2.5 milligrams of oxycodone, say every 4 hours. And that is very, very different compared to, I had a 65-year-old patient with multiple myeloma, which that cancer creates holes in the bones. So it's very, very painful. And for his pain to be managed, he was taking oxycodone 300 milligrams every 4 hours. And for his PRN, as needed for breakthrough, he could take an additional 100 milligrams of oxycodone every hour. So that just shows you how that's someone who's opioid tolerant versus someone who's opioid naive, and just how different, and just how different it can be for the two of them.
Megan, sometimes we need to remember that changing the type of opioid is really necessary if the pain or other symptoms like dyspnea remain uncontrolled. It's all about finding what works best for your individual patient.
Yep. And especially with going back to the elderly population where we might notice
Right.
are starting to have renal failure, or just in those with chronic kidney disease, it's good to avoid morphine, which is broken down and digested down in the kidneys, because it's metabolized there. They can develop a buildup of the blood of the drug, excuse me, in their bloodstream, and then they can just lead to more side effects, such as maybe now they'll get more sedated, or maybe they'll get more nauseous if it's something that makes them nauseous. So fentanyl or dilaudid are better choices because they're metabolized by the liver. And so also too, you might need smaller doses for people that are in renal failure.
And let's not forget this huge concern that nurses sometimes have about opioids potentially causing premature death. It's crucial to remember the intent of giving opioids is to relieve pain and suffering, not to hasten a person's or a patient's death, rather. Our focus is on their comfort and their quality of life. I'll say that over and over and over again, as you know me, right? The patient's dying from their disease process, not from the opioids they're being administered.
Exactly right. Yep. It's their disease process. Yep. It's not the opiate. And the best way to manage someone's pain is by completing a thorough pain assessment, because of the type of pain that they're having. I mean, the location is a good piece, but also like the quality of the pain. What words would they use? Is it something that's a dull ache versus a sharp pain? Then can also give clues as to what medications or what treatments would be more beneficial. And so, for example, um, patients with metastatic bone pain, they need opioids, but oftentimes they'll need an adjuvant, which an adjuvant is another medication that, when combined with opioids, just have that stronger effect. And the steroids are the go-to for metastatic bone pain, and in particular, dexamethasone can be really effective. Um, and something else too, after surgery, I know a lot of dental or a lot of medical practices, they're discharging people home with instructions to take Tylenol and ibuprofen together instead of doing opiates. And I've seen that work. I've given patients opiates before they have back pain from whether it be laying in bed or whatnot. But if we, instead of giving another opiate dose, if I gave a dose of Tylenol or acetaminophen 325 with ibuprofen, then they found that their pain really was relieved much greater than it was from the actual opiate.
It's so important that you brought up pain assessments. Later, I know that later in this episode, we're actually going to talk about nonverbal signs of pain. And that's also important for nurses to recognize so that they can appropriately medicate their patients to keep them as comfortable as possible. So that's a great point.
Yes. And we're talking a lot about medications because in the hospital setting, medications are abundant. But non-pharmacologic interventions are important too, to remember as you're treating someone's pain. So whether it be sometimes for arthritic pain, a nice warm pat can feel nice on on their knee, or doing some relaxation or breathing exercises. There are some guided imagery scripts that you can find. So just, and that can help by distraction to the person just to get their mind off of their pain. So there are a lot of non-pharmacologic interventions that can be utilized as well.
Absolutely, Megan. I consider myself a very holistic nurse practitioner, and offering these interventions, I find, can really show our patients that their holistic well being is our top priority, that we really fully want to address their physical, emotional, and spiritual needs.
Absolutely. And before we wrap up, because we're getting a little bit closer to the end, let's talk about assessing pain in somebody who may not be able to express it verbally. So this might be someone with dementia who, in the later stages of dementia, they lose the ability to talk in sentences, or those that are actively dying. If they're minimally responsive, how do you know by looking at them that they need doses of, if they need to have their pain managed? And it's things with nonverbal signs of pain. So looking at their face, do they have a furrowed brow? Are they clenching their teeth, or are they grimacing? what sounds do they make? So when somebody goes to reposition, if you turn them over and they're yelling out, then that's a sign that they have pain and they need to be managed. Excuse me, they need to have their pain managed before you even go to reposition them. You could give them a dose of a PRN as needed pain medication prior to um, prior to repositioning them. And so it's just really focusing on them, the sounds that they're making, what they look like, that can really help narrow in on whether their pain is managed or not.
Wow, that is so important. I've seen so many dying patients look so peaceful and comfortable until you go to reposition them. And then, minimally responsive patients and patients with dementia, they should really be given scheduled pain medications. We need to remember they can't ask for PRN meds. I've heard a joke that PRN stands for patient receives none. And then that's actually, I hesitate to call it a joke because it's actually terrible that somebody would put a patient in that position. But the truth of the matter is, you and I both know, we've seen that some patients aren't given pain medicines for breakthrough pain because they haven't actually asked for it. I actually had a family member that fell into this position. So we do need to remember that breakthrough pain, needs to be on there, as well as the scheduled meds. Patients, can be too, I'm sorry, I didn't mean patients, I meant nurses. Nurses sometimes can be too busy to remember to pre-medicate, that 30 minutes before or 1 hour before repositioning. So those are the kind of things we need to make sure those patients at least have something in place, and then teach the family members perhaps to advocate for them, or even write it up on the board to remind yourself at times to do that.
Yes, absolutely. Thanks, Elena. And something, so I'm also work as a hospice nurse, and so it's easy to give these comfort medications to patients that are minimally responsive, because if you crush the medication and using a 1 cc or milliliter syringe, you can draw up some apple juice, just like 0.2 or 0.4 milliliters. That's enough to dilute that oxycodone or that morphine 7.5 milligram dose. It's enough that you're able to kind of make like a little slurry, and then you can apply it inside their cheek. Um, and so it's something that, just because somebody is not able to take oral pills anymore doesn't mean that you can't give them in their mouth. You can. I mean, it'll slowly trickle down and they'll swallow it, just because that's a response that we have.
Lastly, we really can't talk about opioids in our current environment without addressing opioid addiction, which tends to be a fear that so many people have. We really need to reiterate that when patients takes an opioid for pain or dyspnea, their chance of addiction is extremely low. And we're talking about individuals that are usually at end of life, and this isn't an issue for them anyway. But people who have addictive personalities and are taking opioids without symptoms, that's what leads to addiction. And so we have to be very careful on how we define addiction, because there are very, very clear definitions for addiction. So therefore, most of these people that are taking opioids under the guidance of a healthcare provider at end of life, as we're talking about, will not become addicted to them.
Yes, I've never seen someone on hospice or in end of life care become addicted to an opiate. And then before we close out this episode, we also can't forget to address constipation, Elena. Actually, I'm sorry, that's mine. So people, those side effects of opiates, they'll get used to. So if somebody is feeling nauseous when they start taking an opiate, or somebody is really groggy, those side effects are ones that the person gets used to. But a side effect that someone never gets used to is constipation. And so opiates bind to the receptors in our gut that stop peristalsis. So if we're unable to have the intestines do peristalsis, you're not going to be producing bowel movements. So it's super, super important that whatever provider is ordering the opiate needs to order a bowel medication. And the bowel stimulants like Senna can be effective. So can Dulcolax suppositories. I have seen just by giving Colace by itself, not effective. Docusate just by
No.
itself has not been effective. And I've heard you can't push mush. So it can help soften the stool, but it's still just keeping it in the intestine. It's not causing that peristalsis versus the stimulants like Senna can help that intestine move the stool along. And even
Well,
if someone is not eating or drinking, they should still have a bowel movement at least every 5 days.
that's a great point, Megan. We need to remember that bowel regimens are tailored to the individual, just like their opioids are, and they need to be taken hand in hand and recognize that if something is not working, there are actually other medications that are not over the counter that providers can also prescribe. So that's a great point.
Yes, yes.
So, with that, I guess we're going to say that's a wrap for today's episode. Just remember, pain management is more than just administering medications, it's about providing person centered, compassionate care, ensuring that our patients' last moments are as comfortable as possible.
That's right. And thank you so much for joining us on this great discussion about pain management and end of life. We hope you found these insights valuable and applicable to your practice. Stay tuned for more thought provoking topics on the Comfort Care Expert podcast. I'm Megan Lefto.
And I'm Elena Prendergast. And until next time, keep advocating for your patients' comfort and well being. Stay compassionate, stay informed. And until next time, take care.
Great. Thank you.